Hello, I'm here with my friends, Dr. Mickey Kaplan and Dr. John Cunningham. We're the co-CMOs of the CCHA, Chicagoland Children's Health Alliance. We are here in this room. We did just take off our masks. We are socially distanced 3 feet apart, and we are all vaccinated. So we just wanted to make sure that the audience knows that. We have several questions that have come up from our physician constituents across our network, and we want to just take some time to discuss them amongst the three of us. So the first question, gentlemen, is can the reduction in pediatric volumes over the last 12 months be accounted for by the pandemic alone? John, what do you think?
I think the answer is yes and no. Firstly, obviously, parents have been keeping their children at home. There's been a reduction in respiratory illness because of everybody wearing masks. But I think the other thing that we're seeing is an acceleration of something we knew about and started planning for before the pandemic, in the context of the reduction in the population in Illinois, but more importantly, the reduction in the birth rate that we've seen over the last almost 10 years. And it's pretty clear that the birth rate, in fact, has decelerated more rapidly than we would have anticipated. And perhaps there may be less than 90,000 births in Illinois this year, which is significant if we look at 5 years ago, where it was about 120, 130,000.
I feel like it's like we've been planning for this, but the pandemic accelerated it. And Mickey, what are you seeing in the NICU?
Right, so I think that reduced delivery volume has been really affecting the volumes in the NICUs all across our system, and frankly all across the country. People sort of initially thought the pandemic would maybe boost the delivery volume, all these parents together all the time with nothing to do, but it turns out that as usual, the delivery volumes mirror the financial situation in the country quite well, and unfortunately that's what we're seeing with the pandemic. But the NICU volumes are down, and we're going to have to be very creative and thoughtful about how to deal with that going forward, unless we see a really nice rebound in the near future.
Mickey, what do you think about the relative ratio of sort of severely ill neonates versus less acute neonates? How do you think that's going to go?
Well, that's another interesting question that is fascinating from my perspective, because what people are seeing, not just around this country, but around the world, is that there's a reduction not only in deliveries, but in premature deliveries. And that reduction in premature deliveries is really confusing. People didn't expect to see that with the pandemic, but it may be related to the fact that women aren't getting out, they're not getting low-grade infections, maybe they're not exposed to different environmental stressors or having some traumatic events that lead them to deliver prematurely. But even with the delivery volumes as they are, I think we're seeing even more impact in the NICUs because we're seeing less preterm infants. And so we have shorter lengths of stay, less sick infants, and another toll, if you will, on our financial budget in the NICU.
So the next question that we have is, how are we addressing this challenge? And I really think that part of this is why we're coming together. As you see the decrease in population, the acuity of illness goes up. So we not only do we have to develop depth and breadth in our network, but we just have to have a size and scale that's appropriate to handle the population size that we presently have. What do you guys think?
Well, Frank, I agree. And when we all started to come together, I think we were probably all guardedly optimistic that this was the right decision and we were going to have synergy and add value to each other. But as the pandemic accelerated everything, I think we're thrilled to be together, working together, because this partnership is going to be able to provide some consistency and some synergy and some baseline amount of volumes that we wouldn't have probably all had by ourselves. What do you think, John?
Yeah, I agree. And I think the other piece about this that is going to become much more evident over the next 3 to 5 years is there's a lot of changes happening for children with really complex diseases. We're beginning to see things that we didn't think would happen, like gene therapy and other cellular therapies are coming to the fore. And we need a large organization, and to concentrate on those really complex kids, we need to actually make sure that that's done. It's difficult to do that as individual organizations. I think the other issue that's going to come up, especially with those treatments, is that they're going to be very expensive. And so being able to do that at scale is going to be very important to reduce the cost both to the child and their parents, to the healthcare system, and to the nation. And so those things are going to become really, really critical over the next while in pediatric care.
Yes, and even in the lower cost areas in pediatrics, we used to all compete. And so we would have to use excessive resources just to compete with each other in very similar markets. Now, with the partnership that we have, we can take advantage of the partnership by putting certain programs in different geographies and compete with others, or be able to attract patients that we weren't previously able to attract. So I think this has really been a win-win for us in that regard.
I would add one thing, and I'd be interested to hear what Frank has to say about this, that we are all now on Epic, and been able to use that data to actually identify children at risk before they actually become ill is going to become very critical. And that's one of the things that is going to be helpful with a very large system, is we'll have an ability to really use our informatics and our technologies to really identify those kids that really need care as early as possible.
Yeah, I think predictive analytics are really going to be important moving forward. Identifying children early on who might require or benefit from novel therapies, and really making sure they get to the right place for those particular therapies.
Right, I mean, from the population health perspective, when you've got 25 or 30 delivery hospitals or neonatal wards to start enrolling patients in and tracking outcomes, it's something that really no one's been able to do for a very long time. This gives us a real leg up on the others around the country.
Right, absolutely.
Okay, so this question is really in three parts, but it's what changes do we see in pediatric practice over the next 3 to 5 years? So it's in subspecialty care, neonatal care, and in primary care. So John, why don't you tell us what you think about subspecialty care?
So in the next 3 to 5 years, I think there's going to be some significant changes in care. The first is, I think we're really going to start to see precision medicine coming into its own. And I'll give you one example. The area of epilepsy used to be regarded as, let's just try one drug, let's try another drug and see what drug works. I think with the identification of a significant number of children who've got genetic causes of epilepsy, and also drugs that interact with those genetic defects, that there's going to be exciting results. So precision medicine is one area. I think the second area that's going to be important is in surgical innovation. I think there's going to be significant surgical innovation in cardiac disease. For instance, the use of cellular therapies, like our colleagues, Drs. Frisella and Hibino, are proposing for children with congenital heart disease. But I think there's going to be other surgical advances as things that have been learnt in the adult world are reduced, and we're in a very good situation. We've got some really outstanding surgeons to think about that. The third area, which is obviously an area that I'm particularly interested in myself, is the area of gene therapy. And if you look at, for instance, diseases like sickle cell disease, we really have not had really much difference in the last 50 years. I can tell you now that there will be a cure for sickle cell disease in the next 3 years, and it will be very pervasive. We will see a very big change in sickle cell disease, and our transplant program our joint transplant program is at the cutting edge of doing that. But there's many exciting things. It's not just in those 3 areas that I mentioned that there's going to be success.
I think we're just at the beginning of this too. I mean, like what we've seen with SMA in the last few years. I mean, we're curing these kids, and so I think these novel therapies are really going to provide different hope for these families.
And I think the other piece that's going to be very important is we truly are going to go to multidisciplinary care. Like we've talked about it for years, that we need, for example, for obesity, it isn't just about somebody a primary care physician. You need a hepatologist, you need a gastroenterologist, you need somebody thinking about nutrition, endocrinology. And that's the sort of thing that our partnership is able to bring together, not just at individual sites, but bring it across the network. We're developing obesity clinics, for instance, across the network. So it's not just even in the very critical new therapies. The way that we think about how we provide care in the community is going to change, and making sure that it's close to home is going to be critical. So subspecialty care, truly close to home.
I know, Mickey, you talked a little bit about neonatal care, but what are you thinking for the next 3 to 5 years?
Well, I think the neonatal situation is a bit more sobering than the complex care that, with all the exciting personalized medicine approaches and such. I don't think we're going to get that into the NICU in the next couple few years. I think we're looking more at how are we going to ration care vis-a-vis having all of our subspecialists. Because when you look at the Chicagoland marketplace, at least, there's way too many level 2 and level 3 NICUs across the geography. And so I envision actually having some of the NICUs having to shrink, lose designation, or close, and set up larger hubs in various different locations where you can then concentrate your expertise and bring all your subspecialty support with you. And so I don't think it's going to be dramatic, but I think particularly if the pandemic lasts another year, we're going to start to see things start to change in the NICUs because of the volumes, because of the expertise, and because of the cost structures that are involved.
But don't you also think, Mickey, that the other reason to do this is because it'll actually drive down the maternal and neonatal mortality rates and morbidity rates by concentrating the subspecialty care and sort of focusing on the kids that are most at risk in the best environments?
Yeah, I agree. I mean, that's always the right answer and the right notion, though trying to decide where women are going to deliver their babies and where to take care of them becomes so complex sometimes. But I agree with you. It makes a lot of sense when you isolate the best expertise, and the more you do theoretically, the better you're going to do it. And we see that already with 22 weekers, which we can all argue whether we should be trying to resuscitate or not. But those NICUs across the country that do that a lot have a much better survival rate than those that don't.
You know, in primary care, I think there's short-term and long-term sequelae from this. What I'm really talking with, when I sit with our primary care physicians, I'm talking to them a lot about the re-entry, right? So as we emerge from the pandemic, we're going to identify kids who for a year have not had care. So we're going to find hypertension, we're going to find obesity, behavioral health issues. So we're really going to have to be good about, I'm calling it re-entry physicals this summer. How are we bringing these kids back into normal social groups, and how are we addressing those issues? I think long-term, you know, pediatricians, pediatric primary care have always been the quarterbacks. They've been the ones that help to, you know, navigate the system for families. I think we're going to need to offer them some support in that area, especially as we see complex kids move from inpatient to outpatient care. We're seeing chronic illness really be cared for in the outpatient space and not on the inpatient units anymore. So how are we preparing our pediatricians to take care of that? And then I think the biggest elephant in the room is the behavioral health piece. So, you know, under the leadership of Julie Holland, we've really been focusing on how are we preparing our primary care workforce to understand, diagnose, screen, and treat basic behavioral health issues, and then what infrastructure are we putting on top of that to support them for those kids that need higher level of care. But I really do think a lot of evolution in the primary care space over the next few years. Okay, so our last question is, how does our collective partnership, CCHA, with the recent additional service lines add value to the pediatric community, the participating physicians, and the patients and families we serve? Mickey, what are your thoughts?
Well, we've talked a little bit about this already, but I'll start with the physicians, and I think the value add there is that we can synergize now. We don't compete. We can work together and isolate and locate our physicians where there's a need without having to have advocate physicians, University of Chicago, and North Shore physicians all in the same geography on the same day. And so we can spread out, get more patients, and then ultimately send subspecialty care to some of the best physicians in the Chicagoland area. John, what do you think? For patients, why does this benefit patients?
Well, you know, I think the end of your question about the new service lines is really quite important. One of the areas that I think we both bring complementary skills to the table is neurosciences. So we have an outstanding group of neurologists who provide broad care across the geography, led by Nishan Shah, and you know his leadership over the last few years has been really outstanding. When we put Nishan together with Douglas Nordley, who is the chief of neurology at the university, who's one of the preeminent international epilepsy program developers. He's developed programs in 4 different markets in the country. I think those putting those 2 guys together, for example, for epilepsy, which is a very common problem for primary care pediatricians, we have the most comprehensive program in the marketplace. For example, our epilepsy surgery program provides all aspects of care for that. That's what we bring to this very large pediatric population that we're all passionate about taking care of. I think we can use similar examples in gastroenterology. We've already shown it in our hematology, oncology, and cardiology practices that we can really, and surgery practices, that we can really bring both the care that's required in the community, and then if there's more complex care, that they're provided to one of our hub locations, whether it's Park Ridge, Oak Lawn, or at Comer. So I really think it's a great synergy.
It's really interesting because there's so many parallels between the neuroscience journey and GI. I feel like we have strengths at all 3 of the organizations, and now together, collectively, we really are one of the best in the region. So I think there's a lot of real potential in both of those areas.
And this is also great for the patients, I think, because they now can be seen locally from some of the best physicians in the community without having to travel long distances, unless they have a very unusual and very rare kind of a illness that really requires a village of services, if you will. So this gives not just the physicians and not just the organizations a head up, but ultimately what we really care for is it's really best for the patients as well.
I think one other thing that I'll get a little off topic here, I think the clinical pieces are so crucial and important, but I think what I've really enjoyed working with you guys is the social conscience that we bring to this. So I think, the fact that bringing these 3 organizations together on behalf of children, we can do a ton of work on social advocacy, on prevention. We have a bigger voice now, not only in the region, but in the country, by speaking collectively on behalf of children. So I really appreciate those conversations with both of you as well.
I would add to that, Frank. I'm thrilled you brought that up. I think the other piece that we haven't mentioned on this telecast is the idea of what it actually may mean for bringing really innovative therapies to children. I think by bringing us all together, there are things that we can bring to the table that none of us as an organization can actually bring. So, for example, we now have a phase 1 oncology program, which we didn't have in the organization, and it's really one of the most comprehensive in the country. That's a rare thing for most children, but I think all of us can come up with 5 or 6 things that together we can actually do together that really bring innovative therapy to the child close to home.